webinar. I am just letting a few people trickle in since we let people into the wait room here. So we'll give it about 1 more minute before we officially start up here. Okay, looks like we're settling in here. So I will go ahead and get us started. My name is Erin Kelly. I am the Director of Research and Evaluation for the Firearm Injury Prevention Initiative with the University of Colorado School of Medicine. Thank you all for being here. The webinar today is about a public health approach to firearm injury prevention, and we're focusing on community firearm violence in this webinar today. Just as a reminder for those who might have attended or have heard about this, but there was a roundtable held in the state of Colorado this summer that really discussed what the firearm related harms were for folks in the state of Colorado. And we were inspired to then use our platform to talk about how we can approach different firearm related injuries and deaths within Colorado from using a public health approach perspective. In July, we held one on firearm suicide prevention, and we're very excited to talk about this today with some of our faculty experts here who I'll introduce shortly around community violence and interpersonal violence. So our goal here is to really talk about and kind of reintroduce the public health approach, and then to talk with these experts that we have here today around how that can be applied to understanding and addressing community and interpersonal violence in that intersection this has with the daily toll of violence from firearms, specifically in the US and Colorado. So our panelists today are 3 of our faculty and researchers who work on community violence intervention and prevention and are associated with the Firearm Injury Prevention Initiative. Given FIPI's focus on collaboration with community and how integrated each of these faculty or researchers are with the community, we do look forward to hosting some of those community experts and partners in a future webinar. But today we really wanted to highlight a lot of their work and what they've known and really kind of work through that public health model with you. So wanted to acknowledge right off the bat that we so deeply appreciate our community partners in this realm and hope to highlight their voices in the next webinar. So I'll kick it off and have them introduce ourselves. Ben, if I can pass to you.
Thanks so much, Erin. And thanks everybody for your attendance. So I'm Ben Lee. I am part of the emergency medicine faculty at Denver Health, and I am an assistant professor of emergency medicine through CU School of Medicine. And I am also the medical director of Denver Health's hospital-based violence intervention program, at-risk intervention and mentoring, or AIM. And I'll kick it over to Ginny.
Hi, everyone. It's good to be with you. My name is Ginny McCarthy, and I'm a doctoral candidate in the Department of Community and Behavioral Health at the Colorado School of Public Health. And I also serve in a development role for GRASP, which is the Gang Rescue and Support Project, which is we'll talk a little bit more about it as we go through, but the umbrella organization for AIM that Ben just mentioned, the at-risk intervention and mentoring program, which is our hospital-based violence intervention program.
And I'm Quentin Myers. I'm an assistant professor in surgery, and I'm a sociologist and criminologist by training. I work with AIM as the evaluator, so I'm kind of the data nerd who is constantly working with our partners to make sure that we have the data we need and to make sure that things are flowing the way that they should.
Perfect. Thank you so much. So before we transition for them to walk through some of their expertise, I simply wanted to do just a reminder and check around what we mean when we say public health approach to firearm injury prevention. So again, that first step is really around surveillance, understanding what the data really say about a problem or a concern that might be at different levels, geographic levels, whether it's in state-specific communities. We're really using data and community voice to understand what the scope or magnitude of the problem is. And then really asking the questions underneath what the data say around injury, death, or other harms, around what those risk and protective factors are. So why are these different things happening within specific populations or geographic locations? Digging really deep to understand kind of what the context or situation around those are. And then from there, it's really to say, okay, now we have data that tell us about what we should be doing to move forward. How do we develop different interventions that really help address those concerns in a community, and then make sure that we're evaluating those to really have the impact that we want to have on those communities and not any unintended consequences. And finally, once we know what's really effective and can work to address some of the challenges we're having in different communities, how do we make sure that that gets out into practice at scale? So to really get this out to those who need it most, and we can adopt that and implement that at scale. So given that overview, I'll pass it back over to Dr. Lee, who will start to walk us through some of the data.
Okay, so first we're going to talk about surveillance and kind of the epidemiology and scope of the problem. And you can see the title of this slide is Violent Injuries, Healthcare, and Society. And I just want to mention that while, yes, firearms are very much the focus of this talk, the conceptual understanding that in community violence and interpersonal violence, firearm injuries don't happen in a vacuum or in isolation, that they are a manifestation of underlying systemic societal, behavioral factors and risks. And an injury might manifest as a firearm injury, but it also might manifest as a stabbing. It also might manifest as a blunt assault. So violent injuries encapsulates those three mechanisms of injury: firearms, stabbings, and assault. So in the year 2020, and these data are a couple of years old, but for non-fatal violent injuries, there were over 1 million emergency department encounters in the US. The vast majority, 9 in 10, were seen in the ED, treated and released. And this kind of speaks to the fact that blunt assaults outnumber firearm injuries almost 20-1. This is very costly to both the healthcare society and also society at large, as you can see those numbers. For fatal injuries, and in this realm, we're talking about homicide, so interpersonal violence that leads to death. In the year 2021, 21,000 were firearm related, and that accounted for 90% of fatal violent injuries. So I think it does speak to the importance of highlighting firearm related injuries, because these account for the vast majority of fatal violent injuries that occur in the community and society. And these also cost our society a lot of money. You can go to the next slide.
And so when we start to talk about who's affected the most by firearm injury and death, this is one of the more recent statistics that we've seen. And if you look at those top two lines, this is the leading cause of death for children. And this is from the American Academy of Pediatrics. And this is pulling from CDC data. But looking at what happened, if you look back previously, motor vehicle traffic deaths were exceeding firearm deaths in the youth population. And so one of the reasons this is most concerning to us, one, is because we've seen a lot of progress in terms of motor vehicle safety. And so we believe that the same is possible for firearm safety in terms of firearm prevention, especially for a vulnerable population like youth. But we also know that youth are particularly heavily impacted by firearm injury. And so if we look here over to the gun deaths, and these data are from Everytown, but they're also using the CDC Wonder data, 62% of child and teen gun deaths are homicide. So when we think about the combination of increased rates in that homicide category for youth, and that youth are affected by firearm injury, it narrows our focus a little bit into say, what should we be thinking about when we think about pediatric death? What should we be thinking about when we think about firearm injury and death? And so further, what this statistic here, what these stats and numbers don't show, is that firearms are the leading cause of death for young men of color, Black men in particular, between the ages of 15 and 34, and the second leading cause of death for Latino men in the same age range. So when we talk about, and we'll get into a little bit more of the the programming around these interventions and these prevention measures, but those are the populations who are most at risk, and those are the emphasis for a lot of the community-based work that we're engaged in, both from the research side, but also from the practice side. And one of the key questions that we talk about is youth access. And so these are Colorado-based data. This is from the Healthy Kids Colorado survey. It's a biennial survey conducted across the state of Colorado for middle school and high school students. And in the 2021 data, we were able to look at what teens report in terms of access. And so a quick shout out to Matt Wettenkamp. This is an article we all kind of worked on together in my graduate research assistantship role, which I forgot to mention, but through Firearm Injury Prevention Initiative, co-authors on this call, Aaron and others, but to say that this is what we're looking at when teens tell us how quickly they can access and fire a loaded firearm without parental supervision or adult supervision. So 1 in 3 have access overall, or reporting access to us overall. 1 in 4 say they could access and fire a gun in under 24 hours, and 12% report to us that they can access and fire a loaded gun in under 10 minutes. So this intersection of increase in homicide, youth suicide still being a primary concern when we talk about secure storage and firearm safety and access. When we talk about what prevention looks like in the community, these are different elements that we're considering, especially because younger populations in the United States are most affected by interpersonal firearm injury. And so as we go through this public health approach, one of the key steps is identifying risk and protective factors. And you'll hear us talk about different risk and protective factors throughout the presentation. But one of the areas of emphasis that we'll start out with pretty early is to talk about something you're very familiar with, the social determinants of health. So these social economic drivers influence health outcomes. And we see that at the bottom, how all of these individually lead to differences in mortality, morbidity, life expectancy, healthcare expenditure, all of these health-based outcomes that in many ways are demonstrative of equity or inequity in our healthcare system, but also in community. And so you can see that middle gray bar that runs through on racism and discrimination. Like I was saying, young men of color are most affected by firearm injury and death. So to understand the roles that structural determinants play, and also these social and economic factors. So likely no singular factor on this map is going to lead directly to one outcome that is adverse, but it's a collection of these and competing levels of priority and competing levels of prevalence that influence an individual's life, but also the lives of their family and the community in which they live, determining resources that they have access to, and understanding how things might play out differently for a different individual in that circumstance. So as we look at this and we talk about risk and protective factors across the board, the more of these factors that someone has in support of them, they have food security, they have literacy, they have health coverage, the less they will be a risk factor. The deficit of these factors becomes a risk factor. So we see these almost like a yin and a yang approach, but to say, if you have employment or your family is steadily employed and you have access to those financial resources, that's a protective factor. And the absence of that is the risk factor. And this is a beautiful infographic that is put together by Cities United, and you can scan for the full report there on the side, which may be more interesting than me talking to you, but the point of entry into this map really depends upon the person from the experiential side. So when we look to community and we talk about risk and protective factors, interaction with these different systems is really what shapes someone's experience, really shapes from the provider side and the researcher side, where we start to look at which risk and protective factors are showing up more predominantly and how we start to address, again, for individuals, families, and communities, what that response mechanism looks like. And so in terms of firearm injury prevention, when we think about things like violence interruption or things like hospital-based violence intervention programs, estimated costs of public safety, these larger pictures come together to talk about or to form the CVI, the community violence intervention ecosystem. And so when we think about developing and evaluating interventions, we really are looking at both sides of that equation. One is who is experiencing injury and death due to firearm, and who is going to show up to start to ask the questions and then collaborate to solve across sectors the problem, honestly, to see what's at play and who can do what, where, what's generalizable and what's specific to an individual or to their circumstance. And so this is the map that talks about community violence intervention. This is the broader ecosystem model. And so everything from crisis management, so showing up immediately, that could be in the street, that could be receiving someone who's in a housing crisis, who's experiencing a health crisis. And these, you see these intersecting by design, right? So it could be street intervention. We'll talk a little bit more about this in Denver locally as we move forward in the presentation today. Peace fellowships, really investing in community leaders, influential individuals and groups by block, by organization, to understand their role, that if there is training and leadership training and de-escalation training when circumstances arise or lead towards violence or could be headed in that direction, what a peacemaker can do and step in to de-escalate or diffuse the situation and redirect resources, everything from mental health to just simple negotiation and separation and understanding the resources that are available for that work. Going to gun violence reduction strategy, targeted trauma-informed care, hospital-based violence intervention, all these different pieces are moving across sectors, whether it's education, healthcare, housing, food security. Some of those earlier social economic factors that influence health outcomes come into play here to varying degrees of relevance, again, depending upon the situation. But to understand that everyone's kind of doing work in different realms, but they intersect with the primary goal of reducing violence.
So hospital-based intervention programs, or I'm going to call them HVIPs from here on out, there are many iterations on the same model, and this is the model for them. And I'll talk about their history on the next slide. But it starts with kind of secondary prevention or a bedside intervention, leveraging the healthcare system and a hospital's place in society in receiving individuals who have survived a violent injury that has happened in the community, that have made it to the healthcare system. And it begins again with the intervention, and it really highlights the individuals who do this work, which are our credible messengers, and they go by many different names in many different HVIPs across the country. With our program in particular, we call them outreach workers. In other programs, they call them crime victim advocates and other similar names. So we leverage their expertise, their lived experience, their professional trainings, which are very robust. And for our particular program, there is an outreach worker on call really 24/7, 365. And when they hear about a violent injury that's coming to the hospital, to the ED, because they all have trauma pagers similar to our trauma surgery team and many other specialty services throughout the hospital, they come to the bedside. And their main role with the initial intervention is to use that moment to help the individual really navigate a very chaotic, unfamiliar healthcare experience. There are many people in scrubs coming in and out of the room, figuring out who's doing what the priorities are, what's happening next, what's the plan. They also help prevent retaliation in the community, and they very much help communicate with family and friends who may be showing up in the waiting room. The second part of the HVIP model is the care that happens in the hospital, which, with some of the robust trainings that happen through our national network, incorporate trauma-informed and culturally responsive methods of care. And then also in many places, the team is involved in collaboration with our social workers in discharge planning, making sure that the patient has a safe place to go. Because oftentimes when an individual is injured in their community, if you bandage them up and send them right back into the same place that they were first injured, the chances of them returning for another violent injury are very, very high, statistics show. The third piece of this is the follow-up services, and these take the shape of mentorship, which we really take pride in, and then also intensive case management, which really addresses all the social terms of health, many of which Ginny spoke about already, and these wraparound services. You can go to the next slide. So the Health Alliance for Violence Intervention is our national network, and I'll just speak to the history of HVIPs. for a second here. So 1994, as you can see the figure on the left, Youth Alive, which is based in Oakland, founded, that was a existing community-based organization. Underneath that umbrella, they founded Caught in the Crossfire, which is the very first HVIP in existence, in collaboration with Sherman Spears, who was paralyzed from a firearm injury. And then just 2 years later, Project Ujima, which is in Milwaukee, was founded as a result of similar circumstances. And so in both of these situations, an individual was, in the first case in Oakland, the individual survived but was paralyzed. In Milwaukee, a young individual was killed, and the healthcare workers who saw those cases looked back at those individuals' medical records and realized that there were many instances in the past that occurred throughout that particular individual's life, leading up to their paralyzation and death, where they encountered the healthcare system, they were assaulted, and then it led to an escalating series of injuries and encounters in the healthcare system until, in the case of Project Ujima, the individual was killed. And so people started realizing that the healthcare system is a very unique setting, and sometimes the only setting where you can intervene in somebody's life and really, like we talked about, perform that bedside intervention when an individual comes to the hospital. In 1998, the University of Maryland launched their hospital-based violence intervention program. And then in 2009 is when Youth Alive, again in Oakland, convened 30 experts to really address this issue and founded what eventually became the hobby, but at the time was called the National Network of Hospital-Based Violence Intervention Programs. So in its current state, there are 50 plus member programs of the hobby. Our program is a model site. They really help with program development and support with a lot of TTA, or training and technical assistance. They have a robust training and teaching faculty. And so 2 of our outreach workers are part of that team of teaching faculty who grow across the country. They do virtual visits with different sites that are trying to start out, get off the ground, and teaching them best practices. There's also a lot of professional development that occurs. And so one huge piece that the hobby initiated was the certification of violence prevention professionals. And I'll have a figure on the next slide that speaks to that a little bit more. But really adding a sense of professionalism, of development, and validation for the expertise that these credible messengers bring to the day-to-day work that might not show up in a bachelor's or a master's, but is just as relevant to the training that any of us in the medical field have. Next is policy and advocacy. And so there's a lot of work that folks in the hobby do from the legislative side. I'm part of the policy and advocacy working group, and we've done quite a bit of work on Medicaid reimbursements. We were able to successfully pass legislation over the last year by a Children's Hospital sponsored bill to allow for reimbursement for the services of community health workers. And we specifically included verbiage that gave credit to violence prevention professionals to be reimbursed for this. And this speaks to one of the more challenging aspects of this work in general, programmatically, which is sustainability, which I'll speak to in kind of the challenges. Next is the research and evaluation piece. And so both Quentin and myself are part of the Hobbies Research and Evaluation Working Group. And so this is really a great group who have really robust conversations about the best practices around the research and evaluation of a very vulnerable population, and really recognizing that all of these efforts have to be community-led, they have to be ethical, and they have to be meaningful. Some of the challenges around this work, I spoke already about the sustainability. And so many programs across the country, if not most, including ours, are currently funded through kind of a smattering of different grants and contracts and philanthropy. And these are all short term. This is not sustainable. And this takes up many resources to have to reapply in the varying grant cycles. We are, again, trying to expand Medicaid reimbursement. So currently, there are 6 states across the country that have passed legislation to allow for Medicaid reimbursement specifically for violence prevention professionals, which is a huge piece, but we're trying to make that even more common across the country. Some of the other challenges are just culture, and part of this speaks to the culture of medicine and academia and the type of work that's been happening in the community as far as violence prevention for years and years. So GRASP, Gang Rescue and Support Project, was founded in 1991. They've been doing this work for a long time before we founded AIM, the hospital-based program. And part of the challenge is some of these types of work are atypical for what you would experience in a hospital setting. And it goes down to even the most superficial level, that when one of our outreach workers sometimes shows up in the hospital, not wearing scrubs, but wearing gear that shows that they're a member of the community, that says at-risk intervention and mentoring or the Gang Rescue and Support Project, that integrating them into part of the care team can be challenging. And some of this is messaging, some of this is education on a broader level. But you can move to the next slide. I'll just talk about a little bit more about the credible messenger piece. And so on the left, you can see this table, and this demonstrates the core competencies of the violence prevention professional certification. And so you can read through those, but for all intents and purposes, much of it is around trauma-informed care and also culturally responsive care. And so I spoke to it already, but our credible messengers really are the most central component of all hospital-based violence prevention programs and community-based violence prevention programs as well, and speaks to kind of the peer or near peer support and all the evidence that is behind those practices. And so this again combines the lived experience and certified training. And so all of our outreach workers in the AIM program are certified violence prevention professionals. The challenges for our credible messengers in particular, less programmatic, but as individuals, there's lots of secondary and vicarious trauma. They are constantly seeing individuals who are going through crisis, who have been violently injured or are at risk of violent injuries. And this can lead to, again, vicarious trauma. There's lots of burnout in this field. There are insufficient wages and compensation. And this goes to the importance of having a national network like the Hobby to try to establish the best practices to be able to support our frontline staff. Again, the cultural piece. So in healthcare and academia, there's a lot of work to do in understanding really what trauma-informed care truly means and understanding one's circumstances when they come to the hospital for a violent injury, and to not victim blame and understand that this is an individual who has been injured and we are there to help them regardless of their circumstances. The professional development piece, we're always trying to get better at that. And then work-life boundaries. Many of our credible messengers live in the communities where the individuals who are injured live and come from, and this is their life's work, and drawing boundaries between work and life can be challenging. And that really goes toward the responsibility of the medical director and program manager to make sure that there are systems in place to support the staff that are doing the work day in and day out. You can go to the next slide. At-risk intervention and mentoring, our program was founded in 2010 by Dr. Katie Bakes at Denver Health. She was an ER doc, and she was also pediatric emergency medicine trained. And she saw the need from the patients that she was seeing in the ED who are violently injured, our youth, mostly youth of color, and how they were not getting the type of support in the healthcare system in the community that they needed, and understanding again that the healthcare system is a unique setting. to be able to intervene in these individuals' lives. So it started Denver Health in the year 2019, 2020. It expanded to UC Health at UCH. And then just last year, we expanded to Children's Hospital of Colorado. We are, one of our strengths and one of the most unique pieces about AIM is that it spans 3 separate hospital systems, and there's no other HVIP across the country that does something similar. Ginny had mentioned this, but so when Katie Bakes saw that there was such a need for a program like this, she looked in the community to try to find a community partner. And that community partner was GRASP, the Gang Rescue and Support Project, which again had been doing this work since 1991, and partnered with them to create the AIM program, which is really a shining example of collaboration and partnership between the healthcare system and hospital and the community. And that relationship has really been sustained and blossomed in really meaningful ways for both the hospital and for our community. One of the other unique things about our program is that we really embrace the cultural aspect of care. And so all of our frontline staff not only get the violence prevention professional training and trauma-informed care, but we also leverage our relationship with a community-based organization called the National Compadres Network, which are based in California. And they do lots of cultural-centered healing that go beyond kind of Western medicine, and really understanding that there are other types of healing that we who go through our kind of standard medical education might not receive. And so really embracing one's culture and embracing the fact that people have different cultures and may respond to healing in different ways than our just physical health, which is oftentimes what we think of. The last thing that I'll mention is that, as I had shown before, the basic model for HVIPs is very much secondary public health prevention. One thing that I think our program also does uniquely well is we really embrace primary prevention as well. And that goes to the fact that we have a great relationship with GRASP, and GRASP has been doing programming in the community for individuals who have been violently injured, but also those who have not been violently injured, in trying to affect their lives and provide different opportunities for them. And I think Jenny will talk a little bit about more about that next.
All right, so if we look back to the theoretical framework that the Javi would identify as guiding the work of HVIPs, we're looking at the social ecological model here. And so really looking at that individual, understanding their circumstances, their personal risk, assets, needs, support mechanisms, education. One of the first things that our outreach workers look at when they initiate a needs assessment with a client is understanding where they're at immediately, what needs to be addressed for their immediate safety. And this, in terms of AIM, this is hospital discharge. In terms of GRASP or community-based programming, it's just the circumstance that they're in. But where are they living? Who's their support network? Is there any threat to their safety, security, mental health? And what do they need to ask in terms of next steps? What do you need going out to that relationship? What do you need in terms of social support, family support? Do we pull in your family now or later? Where does your family stand in terms of a resource to you versus creating challenges for you? Some combination of those is sometimes true. The community, what is happening within the community in which this individual is going back to? And then how does all of this inform some of the societal work that's being done? So Ben was talking about Medicaid reimbursement, but understanding that primary prevention can be addressed through the understanding of our current systems and structures, but can also be supported by the same systems and structures by way of reimbursing for this work. So attending to this individual in their circumstance also comes back through those mechanisms to prevent future injury. When we talk about folks in their circumstance, in their situation, one of the questions or one of the concepts that Ben mentioned as well is the ability for a credible messenger to step in and ask the questions. And so everything from the content of the question to the way in which the question is phrased to that trust that's built through that sense of understanding is a resource that gets added to this individual's toolkit in a sense. So knowing that you have this relationship formed, knowing that they know the resources in the community, and knowing that they're willing to step up for you and connect you. Oftentimes it's accompanying clients, it's driving clients to appointments, it's making sure that if there's a need within the school system or a need within their employment situation, that that's attended to, and that all of those factors together address that secondary prevention in the instance of injury, but then also go through into the tertiary level of prevention, right? So planning out what it takes for this person to take the next step towards healing. But then as an organization, GRASP and AIM are also weighing in on policy level conversations to discuss what it takes to reduce violence within that larger CVI ecosystem, that community violence intervention ecosystem. And so this really is the theoretical framework, this person in context that defines the HAVI approach. And it goes back to this map again, right? So understanding where you enter. So if you're entering, and this is in a future slide as well, and I'm sorry that this QR code is broken, it's at citiesunited.org, but I can also find the direct link once we go into Q&A. But understanding if you enter from the education side, that we're looking hopefully more at primary prevention. Although schools reach out to us when there are instances that happen on school or around school, reach out to GRASP and say, hey, you know, we really could benefit from an outside party coming in who understands what's happening in the community, who can have the conversations with youth about where they are, what's happening. We're working also inside juvenile justice systems and the youth services facilities and the residential centers to say, hey, what's going on? Like, we were just contacted recently to see if we can host a panel. And a lot of the youth who are actually living in the residential youth services building said, you know, we know that we shouldn't have been doing what we were doing. And we want to talk specifically about guns and gun carrying and gun violence because we've learned our lesson in a sense. And we really want to have an open conversation about what it looks like to, when we leave here, not repeating the same decisions or putting ourselves in the same situations where we might be tempted to carry a gun or we might be tempted to use a gun and respond to circumstantial violence or circumstantial threat. And so this is, when you talk about action, this is something that Cities United is doing very well across sectors. And you can follow this roadmap and it goes through. So being able to, Cities United is there are a lot of mayors that come into the conversation here and they understand their individual landscape and they talk with one another about resources that have been effective or plans that have been effective. And so working your way through everything from working to understand where violence is happening, to building the relationships, working across sectors, those multi-layered SMART goals, and to say, like, this is a plan of many years. So when you see in the middle of the map, implement a multi-year plan of action, it's that laying out of this map, but then revisiting year to year to say, did we actually achieve this? Is this sustainable? What's under, like, who can put resources towards this, whether financial or human resources, or rebuilding some of the systems and structures that lead to violence in the first place to address what is needed to come back and do that peace building in, like, the CVI ecosystem map to understand what it means to have an effective HVIP that responds to the hospital, but then releases into case management and ongoing support in the community. So, and everyone enters at a different place, which is something that I think is fascinating about this overall conversation. Much like the CVI ecosystem, under the place where you come in to understand the problem and then the other circumstances kind of relate to those, it's also that way with developing a solution. And so when you get to the bottom of the map, you see develop continuous improvement and evaluation. Lots of different people, lots of different sectors have different roles in this. And so I think it's being really clear about who's in charge of what that looks like and what those outcomes are in terms of hopes for achievement. And so this picture has not been released to the general public yet. So you're the first to see it. This happened this morning. We're all wearing the same clothes. You can probably tell if you look closely, but this was a brunch with our AIM workers, literally just to say thank you, to pull everyone together. And it was organized by the AIM team. We were just privileged guests to be able to attend, but understanding what it looks like to be in community and not ask something. It wasn't a working meeting. It really was just a time to step back and sit and talk to one another. And so, and what happened at that table, which won't surprise you, is a lot of the conversation of what happened at our GRASP Enterprises Academy group last night. Where did those 12 extra kids come from? How do we resource them? Who brought them there? How did those other kids get home? Everything from rides to redeveloping the curriculum, because now we have participants in GRASP Enterprises Academy who range from 10 to 26. And so, as you might imagine, support of those kids looks a little bit, kids and young adults, looks a little bit different person to person. And so this business style academy is actually meets once to twice a week and creates job positions for kids in the program. But then we also hire into the organization to GRASP from there. So as Ben was saying, GRASP is this broader reach. We are working in schools. You see the National Compadres Network logo there in the middle. They have curricula for young men, young women, families, really little kids, up into this pro-social positive youth development model of engagement. And it really encourages kids to connect with themselves, their resources, their inner motivations and drives, what's important to them, and acknowledges the beauty in that and the authenticity in that, and encourages them to become people of their word or their palabra. And so saying, this is who you are, who supports you in that journey. How do we increase the amount of time you spend with those people and in those places, and decrease those other things that take you away from that? What are the things that make you do things that you don't want to do, make you become the person you don't want to be? So how do we balance that out so that this is tipping in your favor? And so it ranges from things like after school activities to weekly healing circles that's part of this curriculum, working in schools, working in the youth residential facilities, understanding what it means to train school staff and administration as well, to say, this is what kids need. We need, the structures that exist. We need to have the students move through the system in the way that they do, but we need to increase the resources available to them by way of personal development and positive mentorship. So GRASP is really, like Ben said, unique in the AIM model in that we have cross-badged outreach workers who go to these 3 level 1 trauma centers. We're constantly being approached to expand the model throughout the city, but then also we have this robust network. And what's not on here is My Outdoor Colorado. We live in this beautiful, resource-rich location in the United States that the mountains are very close, and yet we're taking kids and their families to the mountains for the first time. So understanding what equity and justice and access to the outdoors even looks like, which sounds very basic, like it's right there and it's free, but access and knowing what to do and feeling comfortable trying something new in the outdoors is not available to every kid. So understanding that all these points of contact add up to a support network, and that's what GRASP builds through this outreach.
And so one of the most important things when it comes to these community violence programs too is understanding their effectiveness. Though they aren't new, they're often treated as new by funders and by people who are new to the work. And so we constantly are having to justify ourselves. And one of the ways that we can do that is through research and evaluation. And so just to start, like, where do the stats for violence intervention programs come from? When they are hospital-based, they often come from trauma registries. Different groups across the country have different relationships with their local law enforcement, with their local health systems. And so it kind of depends on what program you're looking at where their stats come from. There's a lot of partnerships with police data. We often can partner to get death data from public health organizations. And then we most often use, and our program specifically uses, an internal database. Specifically, we use Claris FileMaker Pro. Other programs across the country use RedCap. But in general, we use these internal databases, partly because it helps to keep the data in-house, essentially, and it allows the violence intervention workers to own the data themselves, which is really important to do this work. Next slide, please. And so how do we evaluate programs? Unfortunately, one of the most common ways that we evaluate programs is through re-injury or recidivism rates. And this is not the best way to do it. And I'll get into that in a second. We also look at cost effectiveness research. And one thing that the whole field is sort of moving to is adding more qualitative research, because up until this point, there's been a dearth of it. So next slide, please. And so re-injury and recidivism, again, is sort of the most used metric, but it's problematic for a number of reasons. To the point that Ginny made earlier, there's the social and economic drivers, right? There's this whole field of society and this whole section of society outside of our programs, HFIPs and other community violence organizations are not a panacea. They can't fix society. So they can't fix the over-policing that's in the communities of color. And then when it comes to re-injury, it is not always because somebody was doing something negative. They may be doing everything that they could to be pro-social and still unfortunately be in the wrong place at the wrong time. And part of the reason that the field continues to go back to re-injury and recidivism is because there's no real consensus on what other outcome variables we should be looking at. Part of that is because of the Dickey Amendment, which was recently opened up to allow more funding for gun violence research. And so that's allowed the field to start considering what other outcome measures we should be looking at. But up until this point, we haven't really had the funding or the time, because a lot of these programs, the researchers, the evaluators, the medical directors are doing this sort of on limited grant funding and their limited time. And so now we're starting to move into a world where we can look at what the consensus might be for other outcome variables. In 2021, Monopoly and colleagues published an article where they use a Delphi process to try and come up with the outcomes. And our own panelist, Ginny McCarthy, is doing a similar study in her dissertation and comparing to that to help expand what we might be able to look at outside of re-injury and recidivism. Next slide, please. And though in the medical literature, randomized controlled trials are considered the gold standard, and they are in community violence work as well, they're very ethically challenging. It goes back to the points that the hobby standards and indicators want us to be doing ethical research with communities, not on or about communities. And so part of the problem with randomized controlled trials in this work specifically is that it's really difficult to make sure that everybody is getting something and making sure that it's adequate and equal, because it's really hard to assign individuals. And outreach workers have noted in published randomized controlled trials, and our outreach workers have experienced this both participating in RCTs as well as in conversations with me, that it's just uncomfortable to know that you're telling somebody they are getting certain services that other people aren't as well. And it's not something they're particularly comfortable with. So it's ethically challenging both from the researcher side and from the outreach worker side. And ultimately, the clients that we have communicate on a regular basis, and it's pretty likely that there's going to be crossover. Somebody's going to find out that they were put into an arm that is not equal to what the other arm may be, and that creates problems as well. So typically, though these are considered gold standards for showing efficacy, we try to stay away from them. And this past year at the Javi conference, this group here, with in conjunction with one of our outreach workers, actually led a workshop with some of the thought leaders in the Javi to come up with non-randomized controlled trial comparative methods. And it was a really great session. So the next slide, please. So finally, one of the ways that we can talk about cost effectiveness is to demonstrate that this actually saves the hospital money. Specifically, when we're talking about hospital-based programs, it is really important to demonstrate that we are saving money for the hospital, and that is how we can justify our existence. And sometimes it can even allow us to get a little bit more hard funding, so we're not so reliant on grant funding all the time. And one of the most important studies on this came out in 2015 by Juilliard et al. And if you go to the next slide, please. Ultimately, what they found, and I put the graphs up here, you all can peruse them for a second, but ultimately what they find is the hospital-based violence intervention programs actually save the hospital money. In pretty much every way you slice it, it will save the hospital money. It is most effective when the injury that comes in will have a high cost for the hospital. That difference is pretty significant and ultimately saves both the hospital, the patient, and everybody involved money. And so this is really important, but it's also hard to get this cost data. And so there are few and far between where we're actually able to truly look at this cost data. Again, another area where the hobby and other violence prevention programs are really focused on moving in the future. Next slide, please. And so finally, there's a lack of qualitative data. And this goes back, and this is true, this would help all of the associated issues that I've talked about up to this point. For one, qualitative data can allow us to better understand what success means to both participants and outreach workers, so we're not so reliant on what the evaluators and the medical directors and the people who are sitting in our offices and not on the streets every day with our outreach workers see as important. The qualitative data that is out there is typically not done in a rigorous manner, or at least as rigorously as it could be, or it's not what we would typically consider qualitative data. For instance, this book, Wrong Place, Wrong Time, Dr. Rich is one of the founders of one of the earliest HVIPs, and he details his experience with some clients that helped him to come up with the idea and want to really implement this. But it's not what we would consider a true ethnography. It's not how it's not standardized in the way that qualitative data should be, though it is really important and gives us a lot of really great information. And then if we go to the next slide, the other piece of this is that adding more qualitative data, we really need to make sure that we are being community engaged and that it's active participatory research from the community that we're serving and the outreach workers that we're talking to. I do not look like our clients. I shouldn't be the one whose voice is centered and is the one that is pushed out in the research. And as a qualitative researcher, that's really where I hang my hat. I try to make sure that every research question we ask, every interview guide is vetted by our outreach workers. I want to make sure everything makes sense to them and is going to be useful to them, even if it doesn't necessarily speak to the things that hospital CEOs and things like that may latch onto. But the important thing is that it's speaking to the data that the community is interested in so that we can actually start to create change in society versus just in this one individual's life. And I think that's it for me.
That you then. And so this is the last point, and then we can go to questions. I know we're getting right up to the hour, or to conversation. One of the challenges, as Quentin was talking about, is that the implementation of HVIPs is ahead of, or at least parallel with, the development and evaluation of the intervention itself. So what we see is a lot of the science is being developed in ways that we have re-injury, we have cost effectiveness analysis. But what we really want to know is, what are the measures that are closest to the lived experiences of the clients, and how do we inform intervention and prevention through that approach? And so this qualitative aspect of the research is becoming the primary focus in many ways, not leaving re-injury and cost effectiveness analysis out of the equation, but bolstering that with data that actually support the intervention itself. So I think I'll leave it there for a second. It leaves a little bit to be desired with implementation, but implementation really is happening through the HVIP, and that's what I would say. And then the evaluation and the research on that is developing and is supporting the science, or providing the science to support the intervention.
Wonderful. Thank you all so much. We will open it up to Q&A now. And if you want to stop sharing, we can get bigger videos for all of us here too. Thank you. If anyone has a question, please feel free to put it in the Q&A. I know that we did answer some of those as this was happening. While we're waiting to see, I'll start with one of my own. And I will say I thought it was wonderful to hear all of you reiterate really the importance of working alongside community and really centering them in the research and evaluation you do. And just to reiterate, the community-led, ethical, meaningful frame, even talking about centering voice and looking at everything you develop. And I think what my question is really around how you subsequently get buy-in for doing research and evaluation when the central focus is community themselves and they're moving forward in this work, given their expertise in the work?
So I think that hits the nail on the head as far as like part of the reason it's so difficult to do it, because across the country, one of the issues we often see is that violence prevention professionals are a little skeptical of research in general, and so it takes time and it takes care to get the buy-in. I think in a lot of ways, having spoken with my colleagues at other programs, I had a slightly easier inroad because I am from the community that our outreach workers serve. So I know I didn't have the same experiences that they have. I don't have a gang affiliation background, but I did grow up knowing all these people. And so I can sort of speak to pieces of the lived experience and know and come at it with a side of compassion. And I think that's part of how we get buy-in and how you should get buy-in, how I've tried to get buy-in, is making sure that I'm telling them, this is about you. It's not about me. Help me come up with the questions that you need answered so that we can better help our clients. But also, what you're doing is really hard, and I'm not going to pretend to know what you're doing. So how do I would say that's the best way to get buy-in, is to make sure that we are showing them, not just telling them, that they get to lead the process.
Go for it.
I was just going to say, to elaborate on one of the questions that were asked, that I provided just a link to for the VPP training. If you go there, then you can see that it's a week-long training. Sometimes it's done in person, sometimes it's done virtually. The easiest way is if you're part of an existing HVIP, that's a member program. There are some links to reach out for more information, which I would encourage you to do so if this is something that you're interested in. But it looks like they also give kind of cohorts training around when the national conference is, and usually it happens sometimes in the fall. If you just go to their website, it's usually in around October, something like that. So just keep that on your radar.
And then there was a question, Jenny, referencing Johnny Williams, who's the executive director of GRASP, who she was talking about as in terms of credible messenger and how he helps get community buy-in.
Absolutely. And Jonathan, thanks for the question. Johnny Williams is the executive director of GRASP, and he has spent decades, honestly, leading the field and leading conversations with Jonathan, with you, and with others about how to do this work and how to do it well. And so Johnny talks a lot about equity and what it means to have community voice at the table, but to go into a space and have people have the conversation with you, because that's the first step, and to really talk about what's needed, what has worked before, what hasn't worked, and where to go next. And so following Johnny's lead, I feel like a lot of those conversations that happen do center community voice, do bring people to the table that might not come to the table otherwise. And like Aaron said at the beginning, I think there's going to be an entire session in the future with Johnny and others to talk about the work of GRASP and other community organizations that are doing the work. And one thing I would add to what you asked previously, Aaron, about how do you get the buy-in to do the work in the qualitative area, especially, I think we do this delicate dance of giving funders what they want. Here are your metrics and outcomes you've put upon the program as conditions of the funding. But I also have this opportunity to tell you what you need to know. And that latter piece is where our outreach workers really step up and say, here's a story, here's an encounter, here's an outcome. Because if you can have your numbers, and that's fine, and we know they're needed, but if you don't have the stories, the numbers don't mean anything, or don't mean nearly as much.
Perfect. We are at 2:00. Thank you all for attending today. Thank you to the panelists for your expertise and your compassion in this work. And we'll look forward to bringing you all into an ongoing conversation with some of our community experts in the future as well. Have a good rest of your day.